A 58-year-old man presents with chronic right lower quadrant pain, fevers, and a large, expanding, palpable mass. I am showing you two axial contrast-enhanced CT images of the lower abdomen. Describe the findings.
Okay, looking at the images, the CT images demonstrate a massive low-attenuation fluid collection with thick, irregular peripheral enhancement. This massive abscess extends aggressively from the posterior aspect of the cecum, deep into the retroperitoneum, tracking along the right psoas muscle and infiltrating the lateral abdominal wall.
What critical finding is present within the cecum itself that points toward the underlying etiology?
I'd say, crucially, within the cecal lumen, there is a discrete, enhancing, solid polypoid soft tissue mass arising directly from the posterior wall, precisely at the origin of the retroperitoneal abscess.
While severe acute appendicitis or Crohn's disease can certainly cause large right lower quadrant abscesses, what differentiates this case?
So, the presence of that discrete, asymmetric, enhancing intraluminal polypoid mass strongly dictates a malignant neoplastic etiology rather than a purely inflammatory process like appendicitis.
Therefore, what is the primary unifying diagnosis?
The primary diagnosis is a perforated cecal adenocarcinoma, which is now complicated by a massive, aggressive right retroperitoneal and psoas abscess.
Aside from abscess formation, what are two other severe intra-abdominal complications of a perforated colorectal carcinoma?
Based on that, perforated carcinomas can form aggressive malignant fistulas to adjacent structures, such as a colovesical fistula to the bladder or colocutaneous fistulas to the skin. Additionally, free perforation into the peritoneal cavity causes massive pneumoperitoneum and life-threatening peritonitis.
If you were to evaluate the liver on this scan, what specific metastatic appearance would you look for with a primary mucinous adenocarcinoma?
Mucinous adenocarcinomas typically produce low attenuation, cystic appearing hepatic metastases that often contain fine, punctate calcifications.
How would you manage this complex patient as a radiologist?
So, I would urgently consult interventional radiology to arrange for a CT-guided percutaneous catheter drainage of the large psoas abscess. Achieving initial sepsis control is paramount.
Once sepsis is controlled, what is the next step in management?
I would then present the imaging findings at the GI Oncology MDT to coordinate a definitive staged surgical approach, likely beginning with a diverting ostomy or a complex en bloc resection once the localized infection has been adequately drained.